It's always my favorite time to join with you today. We're talking about bladder issues today. So if you have any questions, feel free to log on. And this is where I lost last time. I was turning on my chat screen and I don't know what happened there. So I'm back in business, I guess. So anyway, but before we start with bladder, I did want to bring up issue because there are things that are going on out in the world, whether we like it or not. And they're just things that we need to talk about. And if you've listened to the news at all, you know that RSV, that's a respiratory virus, is going around. It actually, over several years, it's been around for quite a long time, but most people didn't know about it. It was something that would happen to children, very few children. It's kind of a seasonal respiratory virus. That would start out at first. They kind of noticed it, and it would come in the fall, and then there's kind of a little echo rebound that comes like in the January, February months. But it usually mostly affects children. Nowadays, it's affecting a lot of elderly and people with different abilities. So people with chronic illness are more susceptible to it as well. And so it's a virus like any other. It affects the respiratory system. The hospitals, the pediatric hospitals, just get overwhelmed with the number of admissions of children that have this virus because children get dehydrated far more quickly than adults. And so they get very, very sick with this. Older people get dehydrated more quickly, and they get very ill with this, as well as people who have neurological issues can become very incapacitated with this issue. Well, after they started noticing these trends in it, it was kind of coming every other year, and now it's coming faster and more frequently. So that virus is building in the community. So on top of the RSV, which we now have, and we're just coming out of the COVID, but COVID is still out there in different mutations and forms. So we've got that. And it's also flu season. So there we have this triple threat. Now, there's all kinds of scientific reasons why more people are getting these viruses, and they're all, physiologically well laid out. But part of the problem that we're having right now is that we have been so isolated in the COVID that we haven't gone out in society in the last few years. In fact, RSV was almost non-existent during the COVID because people were washing their hands, wearing the mask, not socializing, not going out, doing all the preventive measures that works for COVID, as well as the flu, as well as RSV, as well as colds, and all this sort of thing. So we hadn't been going out. When we go outside, we're bombarded by bacteria all the time, and our body fights most of it off. So we have bacteria around us and viruses around us all the time, but our bodies are able to deal with that. Maybe we get a cold or the flu, but it's not too bad. If you can get vaccinated for COVID, you can get vaccinated for the flu, which reduces the amount of illness that you have, but you can still get it. It can't eliminate it, but you can still get these viruses. So anyway, these are all things that are going on. So a lot of people are hearing about the pediatric hospitals being overflowing. It's also in the adult world because people are getting RSV now more in adults. They're still coming in with various mutations of the COVID, and there's a lot of flu because all our resistance is kind of down, so it's kind of entering our world. So we have to remember to, follow those strategies. If you're going into a crowded space and you have issues, immunocompromised issues, I do. So I wear a mask if I'm going into a crowded space. I'm still going out shopping. I go to the store. I do most of my shopping online now anyway, which, we got real comfortable in the COVID and it was real handy. So we do those kind of things now. So just keep that all in mind. When you're out caring for yourself, if you want to wipe your wheels when you come in, as your hands are touching your wheels that have been outside, if you want to continue to wipe those down, wash your hands frequently, and when you're coming in out of your house. Don't try to avoid touching your face. That spreads all these viruses to yourself. Now, there was an interesting question that somebody had asked me this week, and I would like to repeat it for everyone to know about it because it was a very good question. So the question was that this person is taking gabapentin, the drug Neurontin, which is a drug that you take for severe nerve pain. So gabapentin and pregabalin, they're both known by the trade names of Neurontin and Lyrica. Those are the only two drugs that are specifically designed to treat nerve pain. They're kind of rough drugs to get on. Some people have a lot of trouble getting on the drugs, but if you can last out about 8 to 9 days of taking the drugs, the side effects usually subside in that amount of time. But it's for some people, not for everyone. Some people start taking them, everything's just fine. But for some people, they have a really rough time getting on these drugs. They have some dizziness, their stomach's upset, they blurry vision, and they have a lot of the side effects. But if you can last it out, as I say, problem swallowing is another issue. If you can last it out, it's fine. And they do need to be upped as time goes by. So when you up the dose, you might have that same time period where there's that adjustment time period. But anyway, this person is taking gabapentin and they keep getting conjunctivitis. And so the question was, can gabapentin cause conjunctivitis? Well, a virus, as a matter of fact, causes conjunctivitis. You get a bacteria virus, you rub your eye, or maybe something just flies into your eye. And it grows and multiplies there, especially if you have immunocompromised issues. It's more easily for all those bacteria and viruses and any pathogen to grow. And so does gabapentin cause conjunctivitis? So it doesn't cause it, but gabapentin can lower your immune system. So if you already have a low immune system, or if your immune system's fine and now it's a little bit lower because you're taking the gabapentin, that allows that bacteria to grow more in your eyes, or if if you're getting the flu or whatever it is that's going on. So I just wanted to let you know that if you are taking gabapentin, or Lyrica has the same issue. So if you're taking either one of those drugs, you want to be careful about touching your eyes. You might want to get a pair of, during the COVID when it was at its peak, because none of us knew what was going on with that. I had a pair of safety goggles that we would wear in the hospital, like if you're changing a dressing or if you're working with something that, could fly into your eyes or into your mouth, you would wear a mask. And then we would wear safety glasses over our eyes. So if you're going out, you might want to get a pair of those. You can buy them real cheap on Amazon. And so you might want to wear a pair of those. You can get bigger ones that go over if you wear glasses. So you just might, keep your hands and your fingers away from your eyes, because those drugs, gabapentin, Lyrica, they can give you blurry vision. They can make your eyes itch. So you want to rub your eyes. And then, of course, if you have that bacteria or that virus for conjunctivitis, you can have that. So yes, in fact, gabapentin and Lyrica can make you more susceptible to certain infections, eyes and other things as well too. So just, keep those hands washed, because, we're in that time zone. So a question has come in. I'm going to answer that real quickly. It's about how to heal small but persistent sacral pressure sore. Today's issue is focus on bladder, but no, don't come back another time, because we focus on different things, John, but we answer everything. So don't feel bad about it. If you have a question, everybody has a question about it. So a small but persistent sacral sore, well, that sacrum is a little bony prominence that sticks out right at the top of the gluteal fold. So right where the bottom comes together, right in that fold there is where that sacrum's pressing. And when you're seated, pressure is applied to that. Now, the sacrum's not pressing against the cushion. Usually people have a little more padding there called fat, and they have their pressure dispersing equipment. So be sure and use medical grade pressure dispersing equipment. So your seating arrangement that you have, and make sure it's in good condition, because after a few years, these kind of lose their oomph. Some of them get less air. Maybe the gel has consolidated in some way. They kind of lose some of their oomph. So make sure that your pressure dispersing equipment is still working up to its efficiency. Now, I know insurance does not allow for a new one. Sometimes they break down before it's time for allowable for a new one. So be sure, and if it's not working, you don't feel like you can put your hand under your rear. If you can feel your bones in your ischium where you're seated, those bones under your bottom cheeks. When you're seated, there's some bones there from your pelvis, and then that sacrum's at the end of your tailbone. So it can rub up against a chair. It can rub up against your bed when you're sleeping at night. So be sure you have that equipment that is needed. Sometimes people have seating equipment that doesn't really reduce the pressure around that tailbone because it doesn't hang down straight. It kind of tilts out a little bit. The tip of it kind of tilts out a little bit, which makes a nice little pressure area there. So what you want to do about that is the best thing that you can do for pressure area is to stay off of it. And that's a hard pill to swallow. But if you can stay off of it, then you will be sure and it will heal up, and then you can slowly start getting back into it. That can be a hard thing to do. Now, it's a small opening, but it's chronic. So chronic wounds are a little bit harder to heal up. So you might want to talk to your healthcare professional about seeing a wound care specialist to see if there's something that they can do with that. They might want to put some pads. Put a different dressing on there. If it's open, they might want to put a different treatment on there. They might have an ointment. Sometimes those little tiny sores are open in the skin, but it's much larger underneath. So sometimes they'll want to do an X-ray or a CAT scan or an MRI to see what it's like underneath there. Sometimes those little tiny ones have little tunnels off to different places. And then you need to do different things with that wound because the skin on the outside of the body wants to heal faster than a wound inside the body. So sometimes that skin is closing up and sealing up on the outside, but that wound's still festering on the inside. So you want to be sure and have that checked out. So we're going to assume you've done all of that. So then what can you do? Well, there's all kinds of treatments. You might need a wound vac on there that might help there. Those are done usually in larger draining wounds. This is a small and persistent one, but if it has that chronicity inside of it, that is probably the reason why it's not healing up. So you'll need to talk to somebody about if that skin area needs to be open. Do not do it on your own, because our general rule is we leave the skin alone as long as we can, but sometimes if they have that underneath, you want your healthcare professional to do that in a completely sterile environment. There are some ointments that you can try. Now, I do not know, John, if this is going to be working for you or not. I don't recommend any products. I just speak in general terms. But I'm hearing a lot from the community about this product called Noop, N-O-O-P. You can buy it off the internet. And they have the red spot, not an open wound, but a red spot on their sacrum. And they find just a little dab of that Noop right on there, and it just takes care of it over time. So now, will yours respond to that or not? I have no idea, because first you want to have it checked to make sure it's not deeper underneath the skin, that there's a lot more going on, because you want to get that taken care of, because that will eventually break down, and it'll be a much worse if it still has infection, or if there's a sore, it can go into your bones. I mean, the skin can break down really badly. So check with your healthcare professional. If it's just a surface thing and for some reason it's just not healing up, they can send you to a wound care specialist that will have dressings that will match your particular need. They can look at different kinds of seating. Maybe you need a back cushion that you don't have that will help support that. Sometimes in that gluteal fold, things are moist in there. Now, people don't like to think about this. They do their bowel program and they go on and they're clean and dry, and yes, you are. But from the rectum on everybody, if you have a spinal cord injury or not, There's always gas that is passed. You know, that kid's book, everybody passes gas, or everybody poops, I think it is. Well, everybody passes gas. And that has a little bit of moisture to it. And so inside that fold can be it can be moist, even though it appears dry, because it can be intermittently. So it can be constantly wet. So it might be the kind of thing where you just need to lay on your side or on your stomach. If your breathing is such that you can lay on your stomach, if you can get into that position, and you want to check before you do that, because we don't want anybody to lay on their stomach and have breathing problems. So check with your healthcare professional. Sometimes that area just needs to be opened a little bit and dried out once or twice a day, and let the air and the light get to that. And that, because inside your gluteal fold, butt crack, let's call it what it is. Inside that's a damp or wet, moist, dark area. So it's hard to heal things up there. And that could be all it is. So there's some ideas, but talk to your healthcare professional, because I would be concerned about something going on where you cannot see. And so that can be very important. Oh, and I think maybe I wrote to this person who is, this next question, who's talking about it's winter and they're freezing cold. And unless she's cooking, cleaning, or up, moving around, and using some of her body energy to generate heat, then she's okay. But otherwise, she gets very cold. And yes, that's kind of normal with spinal cord injury. Now, you do have a lower injury, so your upper body can generate a lot of heat. This person has a T11, T12, so they're right at that cutoff zone in between upper motor neuron issues and lower motor neuron issues. That's the area where you kind of get a mixture of both. And so Debbie has probably a combination of everything, and that's why she's getting so cold. It's lack of body movement. So if you can move your legs, exercise your legs, move your body. Now, you can't be doing that 24/7. So like Debbie's doing, sometimes she wants to sit down for a minute, watch TV, or she wants to, relax for a while and do her tablet. I'm always on my tablet. But she's getting cold. So you need to dress differently to trap the heat in there, maybe dress in layers. Wear warmer clothes. You might want to put a blanket over your legs and feet to trap that heat in there, because your body's not generating the heat because it's not moving as much as it could be. So if you can do some exercises during the day to your lower extremities, that's going to help generate some heat, and that will last a little bit longer. But yes, people tend to get overheated in the summer, and they tend to get underheated in the winter. So you've got to really dress differently. If you have some of those fuzzy boots to help keep your feet warm, or, always keep your skin covered, your lower extremity and your skin covered. Now, some people will say, well, I'll sit under an electric blanket, but be very careful with that, because that will give you burns, because you won't feel that it's getting too hot. And I know my son-in-law, thank you very much, bought me one year for my car, a car seat heater that you can sit on in your car. It hooks into used to be called the cigarette lighter, but now they call that thing something different, the electrical charger or something. They don't have cigarette lighters anymore, but that used to be what it was called. I don't know what it's called now, but you plug it into that and it heats up your seat, and it's fabulous. I have sensation, and I feel how hot that gets. And if I wasn't moving or turning it down, I would have significant burns. There are people that will say, oh, we have an electric blanket we can sell you. Oh, we'll guarantee it won't burn your body. Yeah, it will, because like me, I move around when it gets too hot and change my pressure points. But people who don't have good sensation can't move around, and they can't feel when it's getting too hot to turn it down or to do that. So we always say avoid those. So that's an important thing. But yes, and I do hope you got my response, Debbie, because I did respond to you. So my fingers are crossed that I think I just wrote to you a couple of days about this. So I'm hoping that it's somewhere. Please let me know if you did not get that, because we'll be looking for that to make sure it gets to you. So thank you for asking. So anyway, we're going to talk about the bladder today. And we talk about the bowels a lot. We talk about the bladder a lot. Bowel, bladder, skin. Those are the three critical issues that we have with spinal cord injury, but also with other diseases, multiple sclerosis. Spinal cord injury is not just trauma accident. I think people hear the word spinal cord injury and they think, oh, an injury like an accident. But in healthcare, when we talk about an injury, we're talking about something that happens to your body. It could be an injury caused from a disease. So sometimes people get off-put about, oh, they're only talking about trauma. Trauma gets all the attention. No, we're talking about the whole kit and caboodle, disease, trauma, the whole thing, when we're talking about spinal cord injury and disease. Also, people with brain injury who have paralysis from anything. So if you have issues with your bladder, it's a very serious situation. Now, issues with your bowels is a situation too, because if you don't do a bowel program and you have what they call a neurogenic bowel, and that can be from spinal cord injury, from spinal cord disease, from brain injury, from diagnosis like multiple sclerosis. I mean, spina bifida, that, neurological issues. Sometimes people have a diagnosis of neurogenic bowel and bladder. This is a situation where the nerves are not communicating with the brain. Now, in the bowel, people will say, well, I'm constipated, because the stool sometimes looks constipated and sometimes it is constipated. But that's not the source of the problem. The source of the problem is this nerve communication. So if you have a neurogenic bowel or bladder, you have to do a bowel program. This is just the way life is right now. Changes are coming. They're afoot. They're knocking at our door, but they're not here yet. And you can't say, well, I'm just going to wait until new stuff comes out. You have to do this. If you don't empty your bowel, it's going to collect in your bowel and it's going to back up, and you have all kinds of problems with impaction and all kinds of stuff. If you don't take care of your bladder, the problem becomes very serious, because the bladder is where urine is stored in your body until the appropriate moment for you to empty your bladder, which means when you go to the toilet. We don't like to empty our bladder when we're in the middle of a class at school, and we don't empty our bladder when we're like out socializing, in front of other people. That's a private affair. So, but the urine is contained in the bladder. If you have a neurogenic bladder, the pressure in the bladder can be squeezing without you knowing it, and the pressure in the urethra can be closed tight without you knowing it. And so what happens is the urine will back up those two ureters right up into each kidney. The kidney does not store anything. It creates urine from your blood and passes it out immediately. It does not store anything. So if the urine backs up into your kidneys, the only place for that urine to be stored in the kidneys is to press against the very delicate tissue of the kidney. And that destroys your kidney. And then you have no kidney function. And then if that's not taken care of, then you die. You have to go on dialysis. I mean, we're talking serious business here. So you have to take care of your bladder if you have a neurogenic bladder. Sometimes people will say, well, I'll just wait and it'll just roll out. And sometimes there is overflow that overcomes the pressure of the urethra, and you do have an accident. Some people, especially if they have lower level injuries in the lumbar or thoracic area, they'll be doing their push-ups or they'll be pushing up to transfer. They have a little bit of abdominal muscle function and it will come out, and that's called an overflow bladder. That is a separate issue in and of itself. That's a bladder issue that people with neurological problems can have. People that don't have neurological problems can have it, but that is an issue. If you have neurogenic bladder, you can also have overflow, but you have to empty your bladder in some way to get that urine completely out. Now, if you don't have a neurogenic bladder, you can have things like you can have a stress bladder, where the bladder just gets so much urine and just automatically empties. You can have a closely related problem, urgency, where you get the message, you don't have neurogenic bladder, so you get the message in your brain, I have to go to the bathroom right now. And you got to run in there and go right now. I can't wait any longer. And then there's the overflow. And then there's also functional. So some people know when they have to go to the bathroom because they don't have neurogenic bladder, but they can't get there. The bathroom door is not wide enough to get through. They're at some place and their wheelchair won't fit through into the bathroom, or they don't have hand function to be able to remove their clothes quickly enough, or to be able to lower your pants and hold on for balance and get onto the toilet, and they don't have enough time to do all that. And so modifications have to be made to the environment to do that. And so those issues can be treated with medications and timing. Sometimes people who have the sudden urge to go, well, instead of waiting until the urge comes, they'll know they can go 2 hours before the urge comes, or 3 hours. And so they'll just, every 2 or 3 hours, they'll just go to the bathroom to make sure that their bladder's empty. Now, if on the other hand, you have that neurogenic bladder, and that's the one that we're really concerned about with spinal cord injury and some bladder, with spinal cord injury and some head injuries, people get these neurogenic bladders. Now, it all has to do with something called the motor neurons. Those are the nerves. The neurons means nerves, and they supply the motor function to the body. So if those motor neurons are affected, and it can be, usually we think of it in spinal cord injury because if they're affected in the cervical and the neck, or in the thoracic part where the ribs are of the spinal cord, you have what's called an upper motor neuron bladder. And if you have it in the lumbar, in that curve of the back, or down in the sacral area, it's called lower motor neuron bladder. Now, if you have a head injury, you can have an upper or lower motor neuron bladder, and a head injury or brain injury, I should say. I should clarify that. Something that's affected the brain. It could be a stroke. It could be some trauma to the brain. It could be a brain tumor. It could be any kind of thing that's happened to the brain. The start of those motor neurons is in the brain. So depending on if the upper motor neurons are affected from the brain or the lower from a spot in the brain, you could have this upper motor neuron bladder or lower motor neuron bladder. The upper motor neuron is reflexive. It has tone. That's spasticity. If you have tone in your body, spasticity in your body, and you can see it, you can kind of think you might have it in your bladder and bowel as well. And so this is when the internal sphincter, it's very important. There's an internal sphincter up closer to the bladder, and there's an external sphincter outward. The internal sphincter is not under your mental control. The external sphincter is. That's the one, if you have sensation, you can close that external sphincter, and that, well, I can hold my urine till I get to the bathroom. But that internal sphincter is the one that gets the tone in it. And so it can clamp down really tight and just close. And the pressure builds then up in your bladder, which makes the urine go back up. If you have the lower motor neuron bladder, that's areflexic, means there's no tone. And so the urine just tends to roll right out because that sphincter can't remain tight for long. And so if it gets a lot of pressure in the bladder, it's just going to let the urine escape. And so that's why people do bladder management programs, is to keep from having these accidents, which can lead to skin breakdown. And people don't wet themselves out in public. And so that's why we do that. Now, if you have that reflexive bladder, the one higher up in the spine from the cervical and the thoracic area, if you have that reflexive bladder, that is one of the number one causes for autonomic dysreflexia, is something is overfilled or stopping the bladder from urine coming out. And so people get autonomic dysreflexia, and we have a wallet card for that. You can print out, you can carry it in your wallet. You can, if you have to go to the emergency room, or if you're going to a doctor that's new and doesn't maybe treat people with spinal cord injury, maybe they don't know about autonomic dysreflexia, you can put out this card. It has information for the healthcare professional. It tells them exactly where to find the research, exactly what to do, how to treat it. So it's very non-offensive way of going to some place and saying, hey, I have this, I have this autonomic dysreflexia. They call it AD. I think I'm having one of these episodes where your blood pressure goes up 20 milligrams of mercury higher than your normal in adults and 15 milligrams higher than their normal in a child. So you have to know what your normal blood pressure is to know if yours has gone up, because over time, blood pressure after having a spinal cord injury or brain injury, blood pressure naturally goes down in your body. So if you come in and your blood pressure is 120 over 80, they're going to say you're fine. But if your normal blood pressure is 100 over 60, you're having an autonomic dysreflexia episode and you need a medical treatment to treat that. You need to unkink the bladder. You need to empty the bowel. You need to check for something that's too tight in the skin. See, there's those three things: bowel, bladder, skin. Now, it can be other things as well. Talking about using your tablet or your computer, some people have episodes of AD, not the big full-blown headache, pounding headache, blood pressure raising thing. They'll get a stuffy nose. Their eyes get fuzzy and itchy and bothersome because of the light and the computer. The light in the computer is kind of going like this. Now, we don't see that with our eyes, but we pick it up with our brain. So sometimes, you think, I've just been looking at this computer too long. No, it's probably, if you have AD, it could be a trigger for an AD episode. There's some people in the Scandinavian countries that are studying this quite a bit, which I find fascinating. But it was brought to my attention by someone in the community, and we worked through it, and we figured out, hey, you're having AD from being on your computer, because the only way he could not have an AD episode was to wear a baseball cap with a visor on it to cut the light from the computer, and sunglasses, and then he could use his computer. And so that was his answer. But I remember him telling me, I don't have AD because I don't have the pounding headache. But he had the stuffy nose and the itchy eyes. So it comes in multiple forms. So the AD wallet card will help you know about what all the symptoms are, and you can have AD without having the pounding headache. So just something to think about. So talking about bladder management, there are things that sometimes people do, little habits that people get into that they think about, that they don't think about, because, like everything, things become routine and we just kind of do it second nature. Now, when you're first diagnosed and you have to learn how to do a bladder and a bowel management program for neurogenic bowel and bladder, it's so overwhelming. It's so much. It almost takes the whole day just to get all of that organized. And then, but like everything in life, you get into a routine. When you start a new job, it can be overwhelmed. Well, I have to do this, and then we do this, and then oh wait, now something new has come up, and I'm not sure what to do. It's the same thing as starting anything new. There's a lot to take in, and it's really overwhelming, but it does become routine. When it becomes routine, people kind of get a little sloppy, it'll go a little fast or whatnot. So there's some things that I noticed that people do that, that they need to just stop and think about. So one of the first things that I noticed that people do is the first thing they do, they know they have to wash their hands thoroughly before they catheterize, as well as after they catheterize. So the first thing they do is they go over to the sink and they wash their hands, and then they use their wheels and they push to get their supplies, and they use their wheels to go to set up wherever they're going to set up. Their hands have become dirty again because your wheel rims are pretty dirty because you use them so much. So get out all your supplies, wash your hands, be perfectly ready, have yourself exposed so that you don't have to slip down your clothes and touch everything. Wash your hands and then open your supplies, do your catheterization, throw it all out, and then wash your hands again. So that's one thing. People wash their hands and they're very conscientious about it, but they do a lot of things before they touch that catheter. So be sure and think about that. Another thing that you really need to do is to clean the opening to your bladder. And I wrote a lot about angles. I was thinking when I'm driving the car, I do a lot of time thinking, touching my eyes, COVID, RSV. But I do a lot of times thinking when I'm driving in my car. And I was thinking, catheterization all comes down to angles. It's really a mathematical thing. And you think, no, I don't need any math when I cath. And you don't need any math. It all comes down to angles. So in men, to put the catheter in the easiest way, you should hold the penis straight up. Some people will hold it out. Some people will leave it down. But if you hold the penis straight up, you reduce some of the angles inside the body. So when the catheter goes through the penis, there's an angle right at the top of where the penis is and the scrotum, and it's really an angle like this. So if you hold the penis straight up, you reduce that angle. You still have the curve to go around the prostate, but that's a much milder curve because that angle where the penis meets the scrotum, in fact, when you put the catheter in and you're putting the catheter in, if you put your pinky finger right at the base of the penis at the top of the scrotum, you'll feel the catheter hit that place where the angle is. So it's important to note these things because it's just one less thing for trauma when you're putting that catheter in. For women, it's also the angle because women need to separate the labia to put the catheter in. You just need to separate them like this. But when you're trying to maintain your balance and you're holding yourself up, if you're doing it on the toilet or even if you're doing it in bed, of course, we want men and women to do it on the toilet because gravity is our friend in bowel and bladder because it helps drain everything out because the anatomy's pointed the right direction when you're sitting up. So sit up if you can. But in women, when they're trying to do all this, they're going to put the catheter in, they open their labia, they tend to open it and pull it up because the way you're angled, again, it's the angle, which makes the urethra slightly pulled, which can cause trauma when you're constantly traumatizing this urethra, putting that catheter in when it's pulled at a different angle. Now, so when you spread the labia, just open them, but don't pull them up. Now, there is a thing that you can buy, and it's called the labia. I think it's called a labia spreader. It's this little plastic thing. It's very inexpensive. You can wipe it off with alcohol and use it again because it doesn't touch it doesn't touch the urethra, just opening the labia. You can wash it with soap and water. It's a very soft plastic, so it doesn't hurt anything, rub anything. It works out real well. So if you have problems or you want to use both hands for some reason with catheter, maybe a hand to hold on to something and put that in, you can get this labia separator, maybe it's called, but you can get this thing and it's really very helpful. A lot of people like that. Again, I don't recommend anything, but if you think that might be of interest to you, check it out and see if you think that might be of value to you. Lubricate is very important. Again, you don't want to traumatize that urethra. It is moist inside your body, but you want to apply plenty of lubricant to let that catheter glide through. I see a lot of people, you want to drop the lubricant onto the catheter or drop the lubricant onto the clean place where the catheter comes in that little paper packaging, drop it to a sterile place inside there and roll the catheter in it or drop the lubricant onto the catheter. It's sticky, it's goopy, it tends to roll off. So use plenty because especially in men, you've got a long way to insert that catheter. So you want to have that lubricated all the way. You want it to glide in as smooth as possible and you want it to glide out as smooth as possible. Now, research has shown us in men that the most colonized place of bacteria along the urethral canal is right at the tip of the penis. So some people will open that area and clean that area to reduce the bacteria because that's where most of it collects. It's right at that transition from the outside world to the inside world. In women, they haven't done the study, so I can't really tell you about that, but you're more protected by the labia, so we'll see. But you also have more drainage from vaginal or rectal, because it's all connected. So, you know, there's pros and cons to both genders. But if you do, male or female, and you use a cleanser, if it's soap and water or if it's a medical cleanser, be sure and clean that off when you're finished, because if it gets in that moist area of the inside of the meatus, if you're cleaning that area in there, it can be very drying, and then you can dry out the right where the meatus is open. And so that can lead to some problems with erosion and more infection because it's not moist there. Now it's dry there. So be sure and clean afterwards. That's another thing that I see. Do your bowel program, because a full bowel of hard stool is going to press on the bladder. It's going to mess up your bladder program. It's not connected, but it's going to make your bladder not able to fill as easily as it does if your bladder is empty, because that hard stool is going to be pressing against the bladder. It can close off the urethra, making catheterization more traumatic. So you want to keep your bowel program up to date, and also be mindful of AD. Now, some people with men, if they have episodes of AD, so if they have higher level injuries, they might elect to have a sphincterotomy. I've been around a number of years. It was real popular when I started nursing. It went totally out of vogue, and then it came back because of the episodes of AD. So some people have a sphincterotomy done. It's just a little incision made in the internal sphincter, but then urine just flows out. So you don't worry about urine causing an AD episode. Now, you do have to wear an external catheter because urine is constantly flowing out. So if that catheter gets kinked or something, you could still have an AD episode from a urinary situation. But that is the on trend right now. We're going to see how that changes in the near future with all the different things that are coming out with the e-stim and all that. For women, they don't have that luxury, because if you do a sphincterotomy, you're going to be wet all the time and there's no way to contain it. There's been a lot of effort on different female type catheters, but there's not really been one that has met with a lot of success, because the way the anatomy is, there's nothing to really hold on to for that catheter. So sometimes women, sometimes men with retracted penises or difficulty will, and children, this started in children, they'll elect to have a mitral fan-off procedure where they will, it's a surgical procedure where they take the appendix or piece of bowel and they connect the back of the navel, the belly button, to the top of the bladder, and you just catheterize through the belly button. Very handy for females if you're out in the world and, how are you going to get on the toilet? How are you going to spread your legs enough? Female anatomy is very complicated for bladder issues. So, on it goes for the women, but that is another option that people have. Sometimes they'll do a suprapubic catheter, which is a surgical opening through the abdomen right over the bladder, and then a catheter is put in there, and that helps with the AD as well. That's for men and for women. So sometimes that's another option. So there's a lot of different things that can be done to help. If you're having problems with your pressure in your bladder, there's medications. You should have a urodynamic test at some point to establish what those bladder pressures are. Now, we used to say that you need to have that follow-up every year, but the urologists are saying now that, they kind of are able to understand more from urodynamic testing, and your urologist might say, for you as an individual, you don't need to come back but every other year, or I'll just see you in the office, or, there's a whole lot of scenarios. But be sure and check if you have a neurogenic bladder, ask for urodynamic testing just to get that baseline. Because if you know what your baseline is, then you'll know if there's been a change later on down the road. So if it comes out perfectly normal and you say, well, I wasted my time and money on having this test, it's good information to have, because then you'll be able to detect if you come up to a problem and then they have to do it again, they'll be able to say, oh, I see exactly where the problem is because you have a change in this one particular part of that bladder functioning. So these are important things to have. Now, if you have that areflexic bladder, the one that doesn't have tone, I see somebody wrote in, they go every 2 hours. They have sensation. That's great. So, problem solved. Sometimes people who have injury in the lumbar and the sacral might have some kind of sensation. It might not be the way that they had it before their disease or injury affected their bladder, but they might have some sort of sensations. Now, in the guidelines, they say to use the Valsalva, which is that straining, or Crede, which is rolling of the fingers. I'm not going to demonstrate those because I don't want you to do that unless you talk to your healthcare professional. There's been research that doing those procedures can cause the urine to back up into the kidneys. So when you think you're doing these to empty your bladder because you're helping yourself, you're causing damage to your kidneys. So because it's in the guidelines, I mention it. Because many people in the community do it, I mention it. If you are doing that, be sure and talk to your healthcare professional about, could I be having reflux into my kidneys? Do I need a urodynamic test? Is this safe for me? And very well it could be, but be sure and talk to your healthcare professional to make sure that that is the thing that you need to be doing. Now, some people will notice when they have a lower level injury, some people will notice when they do their bowel program that they also urinate. And there is this reflex arc from the rectum that affects, the nerves are all down there. They're all very close together. Some of the same nerves are working double time doing the bowel and bladder, but it's the main branch, but it separates off into the different areas. So, but sometimes people will have this reflex arc where they automatically toilet. So if you have that atonal lower level injury, and you do have urine when you do your bowel program, talk to your healthcare professional to see if you can stretch the rectum, if your bladder will automatically empty. Now, sometimes some urine will come out, but not all the urine. So you need to have testing to make sure what's going on. But sometimes people, they will, with that lower level injury, they do manual removal of stool. And some people get very, very fastidious about it, and they'll just check their bowel every time they toilet. And then if you do that, and you can use that rectal stretch to empty your bladder, well, my goodness, that's quite a little bonus for you there. So talk to your healthcare professional about that. Again, I speak in generalities. This might not be the thing for you. So don't just say, well, I'm going to try that because Nurse Linda said, no, check with your healthcare professional, because we don't want anybody to lose their kidneys over anything that's going on in that regard. Now, there was a question that somebody wrote in, and I want to get to that too. And I pull this up on my other computer. It likes to see my eyes. I'm so advanced technology. I don't know what any of it means, but I think it's really fancy. Okay. Healthcare, I know. Technology, not so much, but we all have our thing. Okay. So this person has a lot of pain and contractions in the body from the level of injury and down, which is what happens after spinal cord injury. Or it can happen in a brain injury on one side of the body or the other side of the body, or it can happen from neurological disease as well. The muscles get locked. So it sounds like spasms, which is now called tone. So I call it tone, but I like to clarify spasms because that's what everybody in the world calls it. But we're trying to move towards tone now because that's more medically correct. And so that's good. We should. But it sounds like spasms, and it makes it very hard to transfer. And I'm sure it does, because everything is just in all the muscles are in action. And the tightness and pressure nail me down to my mattress, making it very hard to rest. So it sounds like you're having some severe tone or spasms. Now, there's medications to treat this. They're oral medications, and they're used a lot. A lot of people take medications for these. Medications that work, you take them by mouth. they work throughout your whole body. So some people will get fatigue, because they're working on the muscles that have tone, but they're also working on your other muscles. So they might feel fatigued, they might have tired, they might feel a little fuzzy in their brain. So with such severe spasms, you might need a medication that works throughout your whole body, because these spasms are from the level of injury down. So you might need to do that, and then you'll have to be aware of those side effects. The side effects do subside over time if you need more medication and you increase your dose, because it tends to be that kind of an evolving kind of process. You'll get those side effects again, so you have to kind of see if you can ride those out. What people are really going for nowadays is the Botox injections. Now, they will do key muscles and in your legs, maybe in other parts of your body. And since you have such severe, you're representing such severe spasms, I don't know if electing to do one or two bigger muscles, if that will alleviate your problems. But that would be the next step, would be the Botox injections. Those have to be done, repeated every 3 to 6 months. And it's, you want to get somebody who does Botox injections for body spasms repeatedly. Now, you can get Botox in your face, and a little bitty tiny amount, so you don't have your wrinkles and, your lines and all that kind of thing. But this is much larger injections. So you need somebody who knows what they're doing, because you can get too much Botox and then you become too flaccid. Some people like a certain amount of Botox where they still have just a little bit of tone, because they will use that tone for transferring. And they'll find a little bit of tone is helpful, but too much tone like this is overwhelming your whole body. So it's got to be just fatiguing and painful, and it's got to be just, it needs some attention. So something else that you can try is also the baclofen pump, which a lot of people use. It's about like this big. It's only about that flat. It's inserted under the skin in your abdomen. So you have a little incision, but it doesn't go through the muscle. It just is right under the skin. And then they'll take a needle when they put new medicine in it, because it has to be refilled, because your body will absorb it. And so the medicine goes right into a little valve that's underneath your skin in your stomach. And then there's a tube that goes around, and it goes into the spinal canal, not into the spine, but into the spinal canal. And it bathes the spine with this baclofen medication, which is a medication for spasms that's taken orally, but this is much, much higher doses. People don't usually move to the baclofen pump as the first alternative. You usually work your way up to this treatment. It is a surgical procedure, and that baclofen drug gets absorbed. Now, it will stay in the lower spine. It's heavier than cerebral spinal fluid, so it stays in the lower spine, so it doesn't affect your breathing, because if it gets up too high, it's going to affect your breathing, and we don't want that. If it gets to be too much, you can be too sleepy all the time. So, a measurement will be found for you and how to do this, which makes it much more appealing. There are some people that have it placed higher in the thoracic spine. It's usually in the lumbar spine, but some people will have it placed higher. I have seen people have it in the cervical spine. You have to have somebody who knows what they're doing there because of the breathing thing. So I have seen it, but it's usually done lower. And then that usually just relaxes the whole body, but it doesn't travel through your brain and affect everything. So that's kind of like the levels. And then there's some more dramatic things, but let's not even talk about that, because one of these other things is going to help. Just getting started on a oral pill is going to be a good start. Maybe start on a real low dose, see how it goes, and then build up to a higher dosage. And then if the Botox injections work, it sounds like you have so much all over your body that I don't know that would be the thing for you, but ask about it, because maybe they say, well, if we correct this one, it's not going to trigger this next muscle and the next muscle and the next muscle. So those are just the way we go. Here, this one guy says his first Botox injection lasted over 10 years. My second one was in April. Wow, that is really unusual. So good for you, Jeff, because that is really great. So that worked out real well for Jeff. It's usually every 3 to 6 months that you have to have that repeated. So that's a good thing. Here's somebody that says, they have a painful, itchy red rash on their arms, which started when they had COVID in August. And I still have the rash. Have you had any patients with this problem? Yes, they have a name for it. It's called the COVID rash. It's a thing. So it's part of the long-term COVID. It is a thing. First started in people's toes, and they called it COVID toes. And then they discovered it came into all different parts of their body. It says that he's had little help from the dermatologist. Please advise. Thanks, Leo. And Leo, I love the name Leo. That's my grandson's name. So, Leo, I love you already. Yes, how is it? I have to tell you, in my last booster shot, I got the rash from the COVID shot, but it was just a small one, and it's itchy, but it's not like I'm all the time. I just sometimes, like, my clothes are up against it and I'm like, is that thing still itching? Because now it's been there for a couple of months. But it's not red all the time. It's not to the severity that you have had, but it's called the COVID rash. You could try, and I have no idea if this will work for you or not, but just like an anti-itch cream to see if that can take off the edge. Talk with your healthcare professional. There's so much about COVID that we don't know, and there's a lot about the vaccinations that we don't know, but we do know that they are safe. So let's just put that out there. It's kind of surprising about the COVID, because people when COVID first came out, we thought, well, people with spinal cord injury and immune problems that comes along with that, and neurological problems, that this is just going to be a horrible scenario for these individuals. And what has happened is that the severity and the death rates with people with spinal cord injury in particular is not that much higher. It's like 0.1% higher than the people in the community that don't have spinal cord injury. And so what's that all about? Well, they think because of the spinal cord injury and the immune response, you can't get that huge crisis that people with the COVID, they get into this huge crisis of this COVID, and their organs start shutting down. It's, kind of similar to septic shock, if in fact it's not septic shock. And, that once you hit that, that's really hard to deal with. And so because people they can get septic shock from infections, but because they don't necessarily have this immune crisis that goes on because their immune system can't react as severely, they're thinking that's what it is. So actually, people with spinal cord injury are faring a bit better than people without spinal cord injury, or at least equal to. So what we thought in the beginning we've learned is not necessarily true. So, that's kind of good news too. So I'm surprised that maybe the dermatologist didn't suggest some kind of anti-itch cream or something to help you out. That seems to me to be the very basic, but maybe he already knows that doesn't help, and I don't know that. But I do know what you're going through on a very, very small basis, because I think mine is starting to go away now. And so I think it will subside over time. But I know mine has been there for now quite a couple of months. So yours has been there for quite a bit longer. So that might be, a lot of people will use home remedies like baking soda on an itch, and I can't really recommend home remedies, but I'm just trying to think of all the things. Sometimes a little ice will temper the itchiness, but you want to be careful of that, because if you don't have a place, if it's itching, you have sensation. So you would know if it was getting too cold there. But, I would try that. And then I'll have to look around and see if I can find anything else about the COVID itch. But anyway, it is a thing. It is a thing, Leo, and it does come from that. So I'm I'm thinking it will get better over time. And so we'll just have to follow that along and see how that goes. So unfortunately, I don't have a really good answer for you, Leo. I wish I did, but I'm going to look into that because now you piqued my curiosity. But anyway, so I thank you all for coming today. It's been wonderful. I do want to point out next Tuesday on December 7th at 2 p.m., we're going to have Dr. Kimberly Anderson Eritzman, who is an expert in spinal cord injury. She's done a lot of basic research things. She's has organized studies in the community. She's just fabulous. So we'll ask her about the COVID thing, Leo. I'm going to make a little note of that and see if she knows anything about it. And because I'm sure she's got issues with COVID in her database. So we'll see if other people have come up with that in particular. Oh, there's one new message. Let me pull down real quick before we sign off here. Oh, thank you. So thank you. So great. Okay. Well, it's wonderful being with you, and I'll see you at the end of December if I don't see you on the 7th. Thanks so much. Bye.